All right, let's get right into it. Welcome to today's Explainer, where we're basically opening up our medical detective case files to untangle the unseen, totally complex world of parasitic worms. We're zeroing in on filarial infections and dracunculiasis. Now, these are super high-yield, fascinating pathogens that honestly can confuse even the most seasoned students and clinicians. But by the time we wrap up this Explainer, you're going to have them perfectly organized in your head. So here's our dossier for today. We'll meet our filarial suspects, look at the night-striking lymphatic filariasis, investigate onchocerciasis, the river blinder, track down lioasis, the day traveler, examine the outliers TPE and guinea worm, and then finish up with a master guide to treatments.
Part 1. Meet the filarial suspects.
Let's meet our primary culprits. In the world of filariasis, it's like each suspect operates with its own distinct getaway vehicle, their vector, and a highly specific striking time. Keeping this straight is absolutely the foundation of our investigation. First, lymphatic filariasis relies on the mosquito and operates late at night, which is what we call nocturnal periodicity. Then you've got onchocerciasis. This one uses the black fly, and get this, its offspring don't even circulate in the blood at all. They literally live in the skin and have no set schedule. Finally, loiasis. This one is carried by the deer fly, and it operates strictly during the day. Part 2. Lymphatic filariasis, the night strikers.
So the pathogens behind lymphatic filariasis, Wuchereria bancrofti and Brugia malai, are incredibly evasive, mostly because their offspring peak in the bloodstream right in the middle of the night. But we can actually catch them in the act without staying up until midnight. Medical detectives use a scrotal ultrasound to spot something bizarre called the filarial dance sign. You can literally see the motile adult worms wriggling around inside dilated lymphatics. It's a wildly specific clue that shows up in about 80% of infected men.
Now, here is where you really need to pay attention because this is a massive exam trap. When a patient comes in with acute lymphatic inflammation, you have to look at the direction the inflammation is moving. Filarial infections cause retrograde lymphangitis. That means it starts at the lymph node and extends outward, peripherally. This is the exact opposite of your standard bacterial infection, which, as you know, ascends toward the lymph nodes. So the crucial point here is knowing how to tell our two night strikers apart. While both can cause severe swelling, like elephantiasis, Wuchereria bancrofti leaves very distinct fingerprints that Brugia malai simply does not. If you were seeing things like hydrophile, funiculitis, scrotal lymphedema, or chyluria, which, by the way, is that milky appearance in the urine caused by obstructed retroperitoneal lymphatics, you are looking exclusively at Wuchereria bancrofti. All right, part 3, onchocerciasis, the river blinder. Our next suspect is Onchocerca volvulus. It's carried by black flies that breed in highly oxygenated, fast-flowing rivers, which is exactly why it earned its ominous nickname. Now, here's a really stark contrast to keep in mind. Think back a minute to lymphatic filariasis, where those big adult worms physically block the lymphatics. Well, with onchocerciasis, the pathology is completely flipped. It's actually the tiny microfilariae that cause all the tissue damage, while the adult worms just sit there quietly inside subcutaneous nodules. And where exactly do those little microfilariae migrate? Right into the eyes. When these tiny larvae eventually die off in the eye, they trigger a massive inflammatory response, causing what's known as snowflake punctate keratitis. Over time, this inflammation progresses to sclerosing keratitis, which tragically stands as the #1 leading cause of blindness from this infection. To diagnose this, you have to remember our earlier clue. These microfilariae do not swim in the blood. So here's another huge trap. If you draw blood, you are going to completely miss the river blinder. You absolutely must take a skin snip to find them. Clinically, you're looking for severe itching, those depigmented patches known as leopard skin, and subcutaneous nodules that usually pop up right over bony prominences. Moving on to part 4, loiasis, the day traveler. Our third major suspect, Loa loa, lurks deep in the rainforests of West and Central Africa, catching rides exclusively on the deer fly. Because of this unique vector, it presents a really interesting challenge for our medical detectives. Think about it. If lymphatic filariasis comes out at night and onchocerca hides in the skin, how in the world do you catch a parasite that circulates in the blood only during daylight hours? The answer is strict diurnal periodicity. You have to time your blood collection perfectly. If you draw blood at 8 a.m. or 4 p.m., you might completely miss it. The microfilaria peak exactly between 10 a.m. and 2 p.m. That tight 4-hour window is your prime diagnostic real estate.
Aside from that perfectly timed blood draw, the physical fingerprints of loesis are pretty striking. The hallmark sign is calabar swellings. These are localized, totally transient patches of intense swelling on the arms or legs, and they're actually caused by a hypersensitivity reaction to the adult worm itself. And of course, the most terrifying but absolute classic sign is when the adult worm literally migrates straight across the subconjunctiva of the patient's eye.
Section 5, TPE and guinea worm, the outliers. So we've covered the big three, but now we really need to examine two fascinating outliers that just don't fit the standard mold. First is TPE, or tropical pulmonary eosinophilia. This actually isn't a separate parasite at all. It's an extreme allergic reaction. When the microfiliaria of W. bancrofti or B. malaya enter the blood, the lungs aggressively filter them out. This rapid clearance triggers a massive hypersensitivity response in the host, resulting in severe nighttime coughing, wheezing, and just absolutely sky-high eosinophils. Now check out this number, 13. That brilliant number represents the total human cases of guinea worm reported worldwide in the entire year of 2022. It is wild to think about, but this proves we are on the absolute brink of total global eradication for an ancient parasite that used to infect literally millions of people.
And that near eradication is an incredible feat, especially when you consider there is absolutely no drug to cure it. Guinea worm is acquired by drinking contaminated water. Fast forward a year later, an allergic blister forms on the lower leg, it ruptures, and a female worm, which can be up to a meter long by the way, begins to emerge. The only treatment is this slow, fascinating, truly ancient process of mechanically rolling that massive worm out on a small stick, winding it just a few centimeters a day to ensure it doesn't snap inside the tissue.
Finally, Section 6, Master Guide to Treatments and Pharmacology Traps. Now that we know the suspects, let's navigate the pharmacology traps. First up is, honestly, one of the most clever strategies in modern medicine. Inside these filarial worms lives a tiny bacteria called Wolbachia. The worms literally depend on this bacteria to survive. So in a brilliant medical twist, we use a super common antibiotic, doxycycline, to kill the Wolbachia. Without their internal bacterial support system, the adult worms just eventually die off.
When it comes to traditional antiparasitic drugs, you've got to keep your first-line therapies perfectly straight. DEC, or diethylcarbamazine, is your heavy hitter. It's the drug of choice for lymphatic filariasis, loiasis, and TPE. But for onchocerciasis, the river blinder, ivermectin is your specific champion. You absolutely do not use DEC for onchocerciasis. But listen carefully, because this next point is the most dangerous trap of all. If you are treating a patient from a Loa endemic area, you must check their blood first. If they have a massive infection, and we're talking more than 30,000 Loa microfilaria per milliliter, giving them ivermectin or DEC will cause a massive die-off of worms right in the brain. This can trigger severe encephalopathy and a potentially fatal coma. It is strictly contraindicated. We've unpacked the biology, the vectors, and the treatments of these incredible pathogens. And we are watching history unfold right now with near total defeat of the guinea worm, accomplished without a single drug. So I'll leave you with this to chew on. Armed with modern medicine and intense global health initiatives, which of these complex filarial parasites do you think human ingenuity will conquer next? Thanks so much for joining me on this explainer, and keep exploring the fascinating world of medicine.